Hi, I'm Tony Trabulsi, neurologist at the University of British Columbia. I'm pleased to present the updated recommendations for using a standardized MRI protocol for the diagnosis and follow-up of patients with multiple sclerosis. This is a project that involves many neurologists, radiologists, technologists, and other experts in the field to try to come up with very practical and useful guidelines for the community. These are my disclosures, and this project was supported by the Consortium of MS Centers. We've been working on standardized protocols and guidelines for clinical use of MRI for almost 2 decades now. Initially started by Don Patey with the Consortium of MS Centers. Professor Patey was a pioneer in using MRI, not only clinically but also in clinical trials for his whole career. The meetings started off in Vancouver and have gone back and forth between Vancouver, where I'm based, as well as Newark, New Jersey. Our last meeting was in October 2019. Our overall goal was at that last meeting was to update the indications and guidelines on using a standardized MRI protocol. And this is really based on new knowledge as well as evolutions and advantages of new technology that's available at most MRI centers. I wanted to touch on the importance of MRI in multiple sclerosis. We're really using it as a main tool to detect the characteristic lesions of multiple sclerosis that we use to help us establish the diagnosis of MS in the appropriate patients. And this will be used to either look for dissemination in space as well as for dissemination in time. It's important that we can rely on this data to detect changes over time and to let us know if our treatments are working as well. Below you can see examples of typical T2 lesions and how they can change with new lesions developing over time, especially in patients who are not treated, and how these lesions can look like with contrast in the final picture. So 2 different ways to detect new lesions, either by seeing new T2 lesions or seeing enhancing lesions, each with their advantages and disadvantages. We also want to be able to rule out alternate diagnoses or complications of treatment, such as infections like progressive multifocal leukoencephalopathy. And there's a growing interest in being able to monitor subtle brain changes, such as brain atrophy. Certainly, patients will move around between MRI centers, even in their own city or across the countries as they move for work. And if there's a lack of standardized imaging, it can be really difficult to detect changes in the short term as well as the long term. And here's a local example showing 2 different sequences on the same patient, and also very different techniques in terms of slice thickness and gap, which makes it difficult to know if there was a new lesion showing up in the periventricular region. And so essentially that's becomes a wasted scan and wasted time for the patient as well as the financial cost involved. We'd like to really avoid that. We think standardized imaging is a good way to do that. Here's an example of the emerging area, which is trying to detect subtle brain volume changes. I'm illustrating this here with a very obvious example. Over 15 years, you can see the enlargement of the ventricles and the deepening of the sulci in this individual patient. We want to be able to detect subtle changes yearly or every couple of years. And so we need good quality imaging to be able to do that. So the recommendations for the standardized brain MRI protocol again highlights tools that are available at most MRI centers, such as using at least a 1.5 Tesla scanner or a higher scanner. 3 Tesla has also become quite popular and quite good. The importance, though, is really having good quality scans being acquired, and so the technologist setting up the sequences really needs to focus on getting a good spatial resolution. Second important aspect is that when comparing MRIs over time, you want to be able to compare the same axis over time, and so if the technologist can reformat or slice the axial sections in the subcallosal plane, that can really make it a lot easier to look for changes over time when comparing studies. It's easy now to get whole brain coverage, but importantly, getting thin slices at 3 millimeters, and with the 3D acquisitions, that's quite easy to do, and trying to minimize any gap between the slices is quite important as well. While scanners themselves may not have changed much over the past decade, the software that drives them has changed quite a bit and makes this much more achievable today than it was even 5 years ago. So we've kind of broken it down to really the core absolute minimum sequences that are required to monitor patients and diagnose them. That would be the standard flare, which is usually required as a 3D is ideal, or a 2D but with no gap and thin slices. And we would like both axial and sagittal acquisitions. And the T2 sequence also is beneficial to look for this subtle sequences, or subtle lesions, especially in the brainstem. The diffusion weighted sequence is quite helpful in the diagnostic workups, looking for alternate diseases. Also is helpful in the monitoring of patients who are on medications that might be associated with PML. If it's feasible, it's also good to get the 3D T1 type sequences. Those are what are required for doing brain volume measurements or brain atrophy measurements over time. Really only takes about 5 minutes from most scanners, and can be a value added as the software evolves to allow us to monitor brain volume in the future. Susceptibility weighted images are also of interest, looking diagnostically for the central vein sign, and perhaps even looking for certain types of lesions that might be more associated with progression in the future, but it's still evolving. It's not part of the diagnostic criteria yet. We'll come back to gadolinium soon, and again, axial proton density sequences are particularly helpful for centers that can't acquire the 3D images. Gadolinium has been a really important contrast agent in MRI, generally quite safe. There was some growing interest in terms of this possibility of some accumulation of gadolinium in central nervous tissue. Here's an example here of a patient who's had 9 exposures to gadolinium, and you can see just a little bit of brightness in the cerebellum, which is typically where we might see some of this accumulation. There hasn't been any clear toxicity associated with that. We've looked at several patients in different studies and haven't seen a pattern of toxicity out of that. However, it's still best to try to minimize the use of gadolinium and use the newer gadolinium agents that are less likely to accumulate in the central nervous system as well. So the scenarios where in the diagnostic workup of a patient, it can be really invaluable in the trying to establish both dissemination time and dissemination in space. About 30 to 40% of patients who have their first attack of optic neuritis or transverse myelitis will have an enhancing lesion. So it's really a high value technique at baseline. It's also very helpful in ruling out alternate diagnoses, especially if there's an atypical clinical presentation or the MRI features are very unusual. Gadolinium can be quite helpful in the differential diagnosis of that patient. In terms of follow-up, we're not recommending it for every follow-up scan. We think with good quality standardized acquisitions, with the same axial orientation on follow-up, you can detect the new T2 lesions quite easily. And the gadolinium really becomes a bit redundant in terms of information. Certainly in a patient with a large burden of disease, it can be helpful in that situation perhaps where it's very difficult to distinguish new T2 changes, but in general most patients will not need gadolinium for their follow-up scans. However, there are some unique situations, patients with very highly active disease or rapid decline, or concern that there might be a different diagnosis going on. So I think in those situations, using gadolinium can really help sort out what's going on in those patients, but it's really case by case rather than on every routine scan. One thing we also updated and addressed was the importance of PML brain surveillance protocol, and this really reflects a subset of patients who might be on medications that are at higher risk for, although rare risk for developing PML. And again, the core sequences remain the 3D axial flare sequences, as well as the 2D diffusion weighted sequences. Those are the bare minimum that are required, and PML does tend to have a fairly unique radiologic pattern that can be seen below. Gadolinium can sometimes help, but it's not considered essential for monitoring for PML. In terms of the spinal cord imaging, we've had a lot of experts contribute to this body of work, and MS lesions in the spinal cord can be quite small, subtle, difficult to detect, and imaging the spinal cord in general can be challenging. There can be motion artifact from breathing or subtle movements, and so we really want to get at least 2 sagittal sequences with differing contrasts, so that if you see a lesion on one sequence, you can confirm it on another sequence to feel confident it's a true lesion. And then having axial cuts through those lesions can be quite helpful as well, just to confirm the lesion as well as getting a sense of its 3D orientation. Orbital imaging isn't required as often to confirm lesions, unlike spinal cord imaging. However, there are some situations, poor recovery, for example, from optic neuritis or progressive optic neuropathy, where having a good quality orbital MRI protocol can be quite helpful to try to sort out what's going on with the visual loss. And again, it is a challenging small structure to image, and there's a lot of fat around the optic nerve, and so having fat-suppressed sequences can make that easier to look for changes over time. And finally, one of the big challenges we've encountered was trying to get more centers from around North America and the world to use standardized imaging. Again, the reality is patients do move around a lot. Even within their own city, there can be different scanners of different quality in terms of the protocol. And it's really wasteful if MRIs are not done of good quality that can be compared to previous studies. And so we've worked with groups such as the North American Imaging and MS Cooperative, as well as the European Magnums, to try to make this a more universally acceptable protocol, and as well as worked with advocacy groups such as CMSC, MSAA, and the MS Society to come up with a protocol in terms of how to broadcast and disseminate these standardized imaging approaches to the MS community. We feel that patients are in a strong position to advocate for their quality of scans that they are essentially paying for. Finally, we're also working with vendors from the major MRI companies to come up with exam cards so that it's easier for individual MRI centers to use the standardized protocols. Overall, we think these standardized protocols will remain quite useful and beneficial both to patients and to healthcare professionals to establish an accurate diagnosis of MS and to safely monitor patients and make treatment decisions based on good quality data. The driving goal was really to make the protocols practical and reasonable. It's not meant to be an academic protocol. It's meant to be a time-efficient, resource-efficient protocol for clinical use. And so we really do hope that this will become more adopted and accepted throughout the community. For further details, please go to the mscare.org website, as we'll keep things updated there. Thank you.